I want everybody in the world to just be educated on it. All pain is not the same. They're just told that this is normal, this is what I went through, and it's really not.
Dr. Seckin, welcome to Good Luck Luk. You are my third physician being invited to this podcast that we have started.
Thank you so much for having me. I'm so honored to be here.
So Dr. Seckin, I know you newly joined Generation X Fertility,
Yes.
2023.
Mm-hmm.
Talk to me about actually before this journey, even when, I don't know how far you want to go, because I know you're also coming from a family of doctors. And how did you find your passion in OBGYN and some of the things that I think you and I feel very, very passionate about, which is endometriosis. So I will let you talk.
Thank you for inviting me to be here again. So I'm so happy to talk about my journey too, because it's never an easy one. It's not easy to be a physician in that path, and every step of the way there's training, tests, and it's still not over for me. It's still not over.
And being a mom.
And being a mom, and that adding to the complication.
Yep. Wife.
So my journey starts as a little kid. My dad is an OBGYN, and when we were growing up, his office was the ground floor of our house in Bay Ridge, Brooklyn. And I was running around there all the time, patients around, pregnant patients getting surgery. I was playing with models of uteruses and
he's an OBGYN.
Yes. He was an OBGYN and did it all back then. But when I was growing up, grew very, very close to women's health. I saw directly how an OBGYN can affect the life positively, be there for the good times and the bad for patients. So I really saw that, and it was exemplified for me. And when I went to college, I didn't really know what I wanted to do. I thought I wanted to do pre-med. So I completed those classes, and I was not ready to apply to medical school yet. So I took a year and did research at Columbia in the Department of Cardiothoracic Surgery.
Oh.
It made me realize that I do want to do medicine, but I don't want to do that. So
interesting. Yes, but process of elimination.
Yes, process of elimination. So I learned then that research is a huge part of this field, or just being a doctor and just understanding that. So that's how that helped me. And then I went to medical school. I went to Jefferson in Philadelphia.
Oh.
And it was a lovely place to go to med school. And at that point, I thought, okay, do I want to do OBGYN or not?
Right,
and I almost did dermatology. I like every field that I really rotated in, except for psychiatry. That was rough. Rough. That's a part of every day, of course, for everybody.
Right. Yes.
So then I thought I really want to commit to helping people through vulnerable things in their lives, and I want to be there and counsel and be that person. So that's why I was drawn again to OBGYN. I thought I can't live without being an OBGYN.
And so I want the audience to know how long the process. So first of all, let's describe one more time. So you finished high school, then you went to college for 4 years.
College is 4 years. And if you don't, I was lucky to have the premonition to do pre-med at that time. If you don't do those pre-med requirements, then you're trapped to having to do more courses between college and med school.
And you have to take all this really hard course like organic chemistry.
Yes, organic chemistry for 1 year and general chemistry for a year.
Yeah, right.
So many different biology requirements.
And then
English requirements.
out of that, you have to take some tests.
Take the MCAT and study months and months for that.
And then that's the 4 years of medical school. So after you, and I don't know what's the selection rate. I don't know if you have the percentage. In the past where, it's like 1,000 applicants.
Yeah, most
10
schools,
people we interview, but I don't know how bad. But basically, it's very competitive.
It is very competitive. When I was applying, most schools had a admission. That when I was applying, that was over 10 years ago.
Right.
The admission rate for schools were like around 5%.
I think it's still
and now
very
it's harder.
It's very harder now.
It's very hard. Application rates, I think, went up
Increase after
30% with COVID because during that year, they waived the MCAT requirement.
Oh, really?
Yeah.
I didn't know that.
Yeah.
Okay, wow.
So they've increased a lot.
Dr. Seckin, you know more.
Yeah.
Yes, I'm
Yeah.
like a little bit detached from that process, but wow.
Yeah.
So, but yeah, you're right. 10 years. You're also now very far from the process already. So 4 years of medical school, and then you have to find your residency.
Then applied to residency.
And where did you do a residency?
I did my residency at Mount Sinai West St. Luke's, the formerly known as St. Luke's Roosevelt's. And it's a nice community academic field hospital on the upper west side of Manhattan.
Yes.
It's a great place to do residency. I learned so much and great.
But it's a big hospital. It's not a community. It's Mount Sinai?
It's sort of a mix.
Okay.
It's sort of a mix. It was a good mix because we really saw a lot. And it allowed us to have our own patients.
Oh, right.
But work with a lot of private attendings.
But it's 4 years. Still.
4 years of
so
residency.
Now it's 8 years.
So that's already 8 years.
Your career.
And then if you decide to do fellowship, if you want to do reproductive endocrinology and fertility, work with patients who are trying to get pregnant, then you have to do another fellowship that's 3 years.
And then you went to Columbia for that.
Yeah, and then I started off at SUNY Downstate.
Right.
That program didn't continue, so I had to transfer, and I was lucky enough to transfer to Columbia and had a wonderful fellowship experience there.
So yes, there's a long journey though. It's not like you have been taking care of lots of patients for 7 years, literally, right? Residency, you have your own clinic, fellowship, because some patients are, it's not new. It's a doctor that has been practicing for 7 years. Because once you go through medical school, in some ways you have a kind of a degree. Then you got a license practicing in residency, and felt like I have my own clinic when I was at Boston. And then fellows, I also was seeing at Yale. I was seeing my own, I have a fellowship clinic where we see our own patients at the IVF center. So after 7 years, then you can go and practice privately or do whatever you desire. But it's a long training, guys. So I just want the audience to know.
Yes, and it's not over yet.
So, Dr. Seckin, why, how difficult, like I was in OBGYN residency, so since we're in the infertility field, and we'll talk about endometriosis in a moment, but is it tough, like how your colleagues, like you have to delay your kind of biological, because in residency, we're already now 20s, right? Yeah, I was in my 20s, sorry, I'm a little bit old
The youngest somebody can really start med school if everything goes by standard timing is like 25.
Yes,
I was 26 when I started because I took a year off. But most people are around that age when they start, and more people are delaying medical school. And then, of course, by the time they start residency, it's later too. So, many girls did not feel, or any of our residents didn't feel ready to start a family when they were in residency. Residency has grueling hours. You still don't have time for yourself.
Not much salary also.
Yeah, not much salary, not much support. And, there were a few co-residents that I had that were pregnant during residency, and they
were working in Boston.
Or
most of them are.
It's so hard. I don't know how they did it, but some people do it. Some people just do it. They have support in one way or another, and they just do it.
In their 20s, right?
Yeah, and more and more. Some institutions are starting to cover egg freezing.
Really?
Yeah, Columbia does that now.
Okay.
For any GME. And covering storage during that time, which is awesome.
Well, I'm lucky because my husband's a doctor, so we went through medical kind of the same year. But that was a big dilemma for me as having baby, because since now we're going to talk about endometriosis, because I had a dermoid cyst in my ovary. And when they operate on it, because dermoid cyst is a very benign tumor, and please, audience, don't be scared. But it is something I was scared because I was rotating through the residency. And I know there's a young doctor's mind. It's like, what happens? I want this out,
Did your dermoid have teeth?
They have hair,
It's
but
just
not black
hair.
It
was different?
Yellow hair.
Sometimes it doesn't match. It's crazy.
It doesn't match. Yes.
That's the funniest thing
Is
about
it 2
dermoids. Well,
centimeter?
I think the matching is like over 75%, but
really? They don't match.
Think.
It was a
They don't
different,
match. Wow.
different hair,
different germ cells,
brown hair, blonde hair, and all kinds of hair. Yeah, we're just talking about the content of the cyst in the ovary. It's a tumor, basically. It's not, but it didn't cause me any symptoms. But then they did a surgery and they discovered endometriosis. And so when I woke up, I remember my REI, because I made a REI doctor do the surgery because I was worried about my fertility. And they said, Janelle, you better have your children early. I'm like, well, luckily, I do have a partner. I was wondering if I didn't have a partner or not even dating, then I would never even have my kids. It's just, and that came to me, and that's how I have my first child during fellowship. But it's still a very grueling kind of journey because endometriosis is painful. I know since we're in the Endometriosis Month, I just kind of want to talk about it. And I know your passion is one of the things that I talked to you about some of my patients with endometriosis, you have such passion. I just want to know, well, endometriosis is basically a disease where lining inside the uterus growing outside of the uterus and can be anywhere. It's just outside. It can be in the bowel, it can be in the abdomen wall. What drew your interest in this disease? What kind of difficulty you found about this disease? And I just want to hear your opinion.
Yeah. So, of course, my father was a huge influence in this because not a lot of people have that niche in treating endometriosis. And he found that niche later in his life as well when he did more and more laparoscopic surgeries and found that this was, hey, excising endometriosis and really looking for the disease in a very specific way does actually help patients. So he started focusing on that niche sometime when I was probably in high school and became more and more involved in that. And then he started a foundation, Endometriosis Foundation of America, which I was volunteering for from the get-go. And I then really saw the impact of what awareness can do for early detection. I saw the impact of what proper excision surgery can do for how patients feel afterwards.
And it does affect young women.
It can affect women.
I remember I was a pediatric
incredibly
in Boston. Boston Children's, and these young women and their parents didn't know why they're in pain, or you try not to go to school, or something like really bad, like to make them feel so guilty, but actually they're really in pain, and sometimes because they are struggling with endometriosis. Are you doing any programs with the foundation in schools or something that can help younger?
Yes, we are. There is something called the Empower program, which is a educational program for middle school and high school girls. It's a video that I helped narrate, and we recorded this sometime last year about what to look out for, how it can impact people, how all pain is not the same, and when to recognize when something is abnormal. Because sometimes when especially a young adolescent reports that they have their first period or some of their first periods in their lives, they're just told that this is normal. This is what I went through. If it's their mother or grandmother or school nurses, this is normal. This is this is your lot in life. And it's really not for some of them. And maybe surgery is not the right thing for a 13-year-old. It may not be, but knowing that this could be a possibility and just at least having that awareness and education is a huge step, because some of these girls that have display these symptoms in their early adolescent years, they're still not diagnosed until decades later. The average delay in diagnosis is 9 to 10 years.
Yeah, 9 to 10 years.
But some go even more than that, and it allows progression of disease. So if they had been doing something else, maybe it wouldn't have gotten so bad, because it's a progressive disease. Not in everybody, but it certainly can be.
That's a good question. So Dr. Seckin, I'm going to have some questions for you. So let's say delays of disease 9 to 10 years. As you know, when I was training, Dr. Luk or Janelle, just give them some birth control pills, just regularly, and maybe you treat a couple percentage of them, because not all of them is going to be resolved by birth control pill. Why not have that mentality? Why discussing about it?
I think that it's just because of that. Like, maybe if somebody was on birth control pills, birth control pills doesn't necessarily prevent progression in everybody. So if they're even on that for more than 10 years, maybe something is happening there, and
now
it's
she's
worth it to
dealing with
discuss.
fertility.
Dealing with fertility, exactly, or maybe more than 10 years later. So really, just educating is very important in terms of like identifying symptoms in other people too, being a support person for each other when you've identified that you have it and someone else knows it, or you don't have it, but you at least know to look out for it and direct people the right way in terms of how to counsel and refer to the right people.
And since we're at the topic, and I'm going to ask you a little bit more personal, and since endometriosis is you and my passion, I don't know how you counsel, but most of my patients are usually with pain, because as you know, fertility is part of endometriosis symptom, infertility. So if the patient is coming with infertility, the first thing is we don't go for surgery. As you may know, we sometimes do IVF, we sometimes do Clomid, we do IUI, and that some patients will be lucky they got pregnant regardless of endometriosis or not. Some patients may need IVF, and then some patients may need the surgery plus IVF to get them to pregnancy. What kind of indication will you do surgery earlier for certain patients?
That's a very good question. I think about that a lot. That's one of the reasons why I'm doing surgery and rotating with the surgical practice right now too, because I want to learn the distinction of which patient would really benefit from surgery first before doing something like egg freezing, embryo freezing, IVF, or IUI cycles. So some of the things I look out for is really debilitating pain. Yeah. And that's one thing. if they're already in the middle of cycles and they really want to preserve the eggs before doing surgery, I think that's fine. But then maybe doing surgery before an embryo transfer is a discussion I like to have. Another indication is really large endometriomas. If endometriosis like that are over even, obviously there's the criteria of over 4 centimeters, but ones that are really bigger than that, then there's a higher risk of rupture. When an endometrioma ruptures, it can cake over the whole abdomen and cause gluing of organs, and that's not good, and it feels terrible for patients. So that's one reason I would recommend doing surgery
endometrioma
first.
Is the hemorrhagic cyst
or chocolate, known as the chocolate cyst, where the blood contents that had probably come from retrograde menstruation just invaginate and to make a life of their own within the ovary, and it can grow and grow and grow because that's hormonally responsive tissue too. So so there's no guide. I have the same problem. It's not black and white.
It's not black and white.
So you have to navigate it on a case by case. Like it's a personal choice. Like you really have to talk to the patient directly about these are the options. This is all we know. This is what's out there. This is what we would recommend, and ultimately it's their choice. We give our recommendation, but
so Good Luck Luke was started obviously for patients and people who are suffering from infertility to hear there's a voice out there, a community out there, they don't feel as lonely. But obviously we were just before our podcast started, we are 2 female doctors and going through the whole journey of being a physician and being a mom. I just want you to share some insights, how the process been. I know now you're a private physician joining private practice. How's the balance between life and work and has been for you? How do you love, this is what you have looking for to practice?
Yeah, it's
in the private setting.
It's definitely tough balancing being a mom of 2 really young kids and just, starting my practice. I don't know how anybody does it in residency or I had 1 kid in fellowship, but now there's 2, so it becomes even harder. I think it's an exponential hardness, more than double. But having kids really keeps me going every day in work because this is what I'm trying to get my patients to have too. And I see the joy I have with my kids, and I want my patients to achieve that. And it really helps me and reminds me every day what the goal is. But yeah, it's an interesting balance and it's tough, and especially I'm still pumping like that. Everybody knows about my pumping and this and that, but one day that'll be over soon.
No problem. And it is a journey, but I think you do enjoy women's health in certain perspective. What do you want to see the field of fertility care or the field of infertility in this coming 10 years? What are the innovations in endometriosis or in the technology? What are the new things?
Well, for fertility care, my dream is that everybody has covered egg freezing up until like 15 eggs or something, and they do it in their 20s, and that could solve so many issues later on, and that would be awesome. One day, I think that could happen. I really think that could happen. In terms of endometriosis care, I want more patients and everybody in the world really to just be educated on it. Just how somebody knows that you could possibly get a UTI or cancer, God forbid. I want everybody to know about endometriosis because very few doctors know about it properly. Very few OBGYNs know about it properly in terms of like what the next steps are, what the best next steps are, and who to refer to. And then lastly, there aren't enough good excision surgeons out there. So educating more surgeons on like what to do, having people having the passion to do the surgery. The biggest problem is insurance doesn't cover it. Yes, it covers some endometriosis surgery, but the reimbursement for it isn't what it requires. Endometriosis surgery can be as long as a cancer debulking surgery. So it's not.
I didn't even know that.
It's not attracting the most talent and time from the surgeons that have the skills.
The talents, right?
So that needs to change. And I think it will change.
You think it will change?
I think it will change. Endometriosis Foundation is trying to advocate at ACOG, and the ACOG is trying to advocate too for changing the codes. I believe so. I mean, it's
a working process.
It's a working process.
The insurance is not easy. The process to get it, there's lots of legal politics and that beyond us can
Yeah.
sometimes control. And, you know, I know you've been practicing now, you know, you've been with us. How has it been in terms of, I know the patients, you know, have to go through tough times of fertility. What kind of wisdom words you can share with the audience or patients who are seeking their doctor or not yet found the right doctor? What are the things that you want to share with those patients?
My best advice for those going through the journey is to seek communication. Oh no, you're a doctor. Seek communication. It's understanding and educating yourself really helps through the process. And I like when people do that. And I like it when my patients understand what's happening, why we make certain decisions, why we do what we do, because it's not an easy process. And this is what I say all the time to everybody is even when things go smoothly, going through fertility care is not easy. Even when everything happens as we expect it. Still emotionally, physically, financially, schedule-wise draining. So we're there to help our patients, and I just want them to know that this is a relationship. That's all.
Thank you so much, Dr. Seckin. This is great. Yeah. And so thank you for coming out.
Thank you so much for having me.
Podcast.
This was great.
Thank you.